Good afternoon, everybody, and thank you for having us here to present today. So I'm here with my colleagues Dan and Isobel, and we work at the Office for National Statistics in the Health Analysis and Pandemic Insight Directorate. So we do a lot of work on mortality and health more generally. And here today we are presenting the work that we've been doing, combining data from electronic health records from the NHS with non-health data. So we started with census, so integrating electronic health record and census, and now we're also trying to add other administrative data sets together. So the talk is going to be in 3 parts, hence why there's 3 of us. First, I'm going to talk about the data and how we put together the data sets. Then my colleague Dan is going to mention how we've used this data during the COVID-19 pandemic. And finally, Isobel will discuss some studies that we've done post-pandemic, meaning not on COVID, actually. So broadly, I mean, you probably all know this, but there are, when you look at the research on health, that's roughly 2 types of data sets that are used by analysts. And I'm expecting that most of you are familiar with the electronic health records that are being used, that you probably use in your job. They contain, so it's all the data that are produced as a result of health care and provision. And yeah, these data are very messy, but are curated by NHS and by some of you. And the benefit of the data is it provides a very comprehensive medical history of people. So you can use the data set to look at the treatment, people have a condition, they have the diagnosis. But the limitation of this data is that it tells you very little about people, about the circumstances. So I mean, you do have information on health, sex, ethnicity, and usually we derive some measure of deprivation based on the address. But we don't really know much about people. What jobs do they have? What is their religion? Are they migrants? What is their command of the English language? All questions that might be relevant when we look at the social determinants of health. That's why we wanted to start integrating, combining the 2, the strengths of surveys with electronic health records. And the starting point was the census, because the census, if you think about it, is collected every 10 years, but it's nothing but a massive survey, essentially, of everybody. But the information that is collected in the census is self-reported. So it's really asking people about their job, asking people about whether they have a disability, and a lot of other questions. So what we started doing is combining, the idea was to try to combine electronic health record with census. So here I'm going to mainly focus on the 2011 census, because that's what we did initially, but we have been doing the same type of linkages for the 2021 census. So what we did was take all the census, the respondents to the 2011 census, and then do a linkage to the, so try to find the NHS number for the census respondents, because the idea was that once we've linked to census, once we've got the NHS number for census respondents, we can very easily link to every other NHS data set without having a need to do bespoke linkages between every specific, between direct linkages between census and every specific NHS data set, which would take too long and would be very impractical. So that's like the course. So the census was linked to the 2011, 2012, and 2013 patient register. So that's when you do a new job, I imagine most of you work just with NHS data. So when you do link data set, you just do it on the NHS number, it's really easy. But here, obviously, we didn't have that luxury. We had to get the NHS number. So the linkage is done on names, date of birth, postcodes, and using deterministic linkage. So when you find typical match and then probability linkage. And we achieved a linkage rate of about 95%. Obviously, it's very important to look at, not everybody will link, right? So there are differences in linkage rates. So if you look here by ethnicity, as you would probably expect, people from ethnic minority groups who are not white, British, have a lower linkage rate than people who are from the white and especially white British group. To a large extent, this is due to differences in linkage rate by age. So you can see that because we use address in the linkage, people who have a different address when they respond to census and as recorded in the patient register will not link. And you can see that typically soon people, young people have less likely to link. So that's a bit of a problem, but it depends what health outcomes you analyze. So it's something to bear in mind. So we've constructed a cohort based on 2011 census. So that's basically the 2011 census linked to all the data sets, the hospital record, the hospital statistics, the death registration data, and data from improving access to psychological therapies. And we are constantly trying to integrate more data sets. So we are harassing the NHS and digital, and now harassing NHS England for more data. And we also integrate, I think our USP really is integrating data from non-health data. So now we are integrating data from HMRC, pay-as-you-earn data, which will provide information on earnings, etc. So in terms of coverage, so who is in this cohort? So on the left, you've got the coverage in 2011. And that's obviously a product of the response rate to the census, which is about 95%. And the linkage rate. So you can see that the coverage overall is for male is 87.5% of the population in 2011, and 91% for female. And you can see that the coverage is worse for younger people, especially for younger males, who tend not to respond to the census and not to visit a GP very often, and therefore their information in the patient register might be out of date. Because it's the cohort that is not being replenished, obviously the coverage is decreasing over time. So we've got about 90% at the beginning, and it goes down to about 80% in 2020. So the cohort is only based on people who respond to the census, so that can cause bias. For instance, anyone who's migrated to England since the census wouldn't be included in the cohort, so myself would be excluded, for instance. So obviously, as someone said before, all data set have limitation. It's about knowing about them. So what data we have? So in here, so we have obviously the data from the electronic health record at the bottom, so death, hospitalization, and more and more. And more importantly, is all the social demographic characteristics that we have that go far above and beyond what is collected in electronic health traditional electronic health records. So we've got marital status, main language, educational attainment, etc. We've got a lot of information on living conditions, and now with the data on labor market outcome. So obviously the main limitation is that the data are collected in 2011, and obviously some of these factors are likely to change over time. So that's why we want to integrate more and more data from administrative data to be able to derive time varying information on people. We also created specific data sets for the COVID-19 pandemic. So that the main addition to this was the inclusion of primary care data from the GDPR. And so the data set here was the cohort was people who were both in the census and also were registered with in primary care. And the reason we did this is because obviously some people who are in the census and linked to the patient register may have migrated out of the country, but we will not know about it. So by conditioning on also being in the primary care record, that was really a way to adjust for migration. And then it was linked to loads of all the usual COVID data sets. So what are we doing? So as I said, we are now building similar cohorts with the 2021 census. We are adding more and more data set from NHS England. The maternity self data is one of our priority, as well as the community service data set and mental health service data set. We're also adding more data from some non-health data, so DWP benefit data, and some educational attainment data from the Growing Up in England study. So the goal is to make the data available on the integrated data service. So I don't know if anyone here has heard of this, but it's a new trusted research environment being built by the ONS, and it's and the idea is to have one platform for all users, and where all data set from all government departments will be sitting. It's a very good idea. It's probably going to take a bit of time for it to be implemented and fully operational, but the goal is for then any analyst in government or in academia to be able to access all these linked data sets for research. and analysis. That's all for me, and I'm now going to hand over to Dan, who can talk about the review the data set to respond to COVID-19.
Thank you, Ray. Yeah, so as Ray said, I'm just going to do a very quick whistle-stop tour of a few case studies that we worked on throughout the pandemic. These were quite impactful, influential pieces of work. Lots of media pickup, really informed the public debate, but probably more importantly informed the pandemic response and the public health response. Lots of talks and papers going to SAGE and occasional briefings and presentations to ministers, right the way up to the Secretary of State and the Prime Minister as well. So this was some fairly influential analysis. I don't know if you can actually see that. I can barely see it from here. So I'll tell you about it. So this was a study looking at social demographic inequalities in case rates according to Pillar 1 and 2 testing during the pandemic, during the second and third waves of the pandemic. So they've already talked about the public health data asset in the cohort. This is a data set of about 40 million people, and we calculated crude and fully adjusted rates and odds ratios of having a positive test in Pillar 1 or Pillar 2, testing across a number of different characteristics, and these models were adjusted for lots of things on the census, so age, sex, ethnicity, religion, measures of deprivation, area of residence, community establishment, and so on, and also a range of comorbidities derived from the primary care data, which were taken from the Q-COVID risk prediction algorithm, which I'm going to touch on in just another slide or two. So what we basically found was that there were some substantial differences in the findings between the second and third waves of the pandemic. So in the second wave, we found that the odds of testing positive were highest in ethnic minority groups, particularly South Asians, Muslim and Sikh religious groups, people in more deprived areas of disadvantaged socioeconomic position, care home residents, and so on. In contrast, in the third wave, we found actually the odds of testing positive were highest for people of white British ethnicity, people of Christian religion, non-disabled people, and people in less deprived circumstances. There's some quite marked differences in the probability of COVID positivity. This was a study looking at vaccination rates amongst older people, so age 70 plus. This is obviously the group which are most at risk of the most severe consequences of COVID if infected. This was looking up until March 2021, so quite early on in the vaccination rollout. So what have we got here? 6.5 million older adults who responded to the 2011 census. So again, crude rates here of vaccination, and here adjusted odds ratios for not being vaccinated. So what we see is that we actually found the biggest differences in terms of ethnicity and religion. So up here we see the black groups have the lowest rate of vaccine take up. You can see here the odds ratios are 5. So black people have 5 times the odds after controlling for other factors of not being vaccinated compared to someone of white ethnicity, and similarly Muslims about 3 times the odds of not being vaccinated compared to Christians. So again, some quite stark findings there in terms of vaccine uptake, and obviously some quite substantial implications for public health early in the pandemic. This was a study, there's no way you'll be able to see this. So this is a study looking at ethnic differences in mortality between mostly into the third wave we were interested in here, and whether vaccine uptake could account for some of those differences in mortality experience of different ethnic groups. So this is during the third wave. The reference group here is white British, and what we can see is the pink lines here are age adjusted. This is males on the left, females on the right. These are age adjusted hazard ratios from a Cox model. What we can see is these are the age adjusted results, and then here throughout the rest of the bars we do sequential adjustment for a range of different socio-demographics, basically things which could be related to either the risk of being infected with coronavirus or the risk of dying once infected. We control for a whole range of social demographics. We control for comorbidities, and then the very bottom line, which is the salmon line, at the bottom is after we additionally control for vaccination status, because obviously we know that different ethnic groups are more or less likely to be vaccinated than others. And what we see is that after we do all of that, essentially, in contrast to what we saw in the first couple of waves of the pandemic, there are really no differences between once you control for all these social demographics and once you crucially control for vaccination status. There's really no difference in the there's really no evidence of difference between ethnic groups. A lot of it's driven by social demographics, and a lot of it is driven by vaccination. So it's except for the Bangladeshi group, where we still see some quite stark differences here, even in these salmon lines at the bottom, which are unexplained by these factors. And